No, 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 I'm sure. Okay, so we're talking about anticoagulants as a high risk, and I won't repeat it because, as it's written, it's really something that poses significant risk to patients, especially in hospitals, where you can argue that. Thank you. You can argue that patients usually take medication all over their life cycle, not just in hospitals, but during hospitalization, there are some elements that make anticoagulant therapy more at risk, more dangerous, because the patients are more vulnerable, and there are different anticoagulants that are not used at home. So there is a need to be more vigilant regarding anticoagulants. Now, I'm proud to say, Amit, one of our senior clinical pharmacist, is here with us. So at the era of fake news, she can guarantee that I'm saying the truth, that before I knew what ISOP is at all, in 2012 actually, a short while after coming back to Carmel Hospital when I did my internal medicine residency and coming as a clinical pharmacologist and reestablishing actually the clinical pharmacology and toxicology service in our hospital, I immediately understood that anticoagulants are really a dangerous topic that should be addressed. And this was the year where docs first was registered in Israel. So one of the things that I did, okay, we are in the early days of like waves coming, because we knew that Pradaxa was coming in, and later the Xarelto, Rivaroxaban, and Apixaban, Eliquis, and I wasn't that clever. I mean, everybody could foresee that it's going to be very, very complicated to physicians that knew only warfarin, enoxaparin, Clexane, Coumadin, and that's it. And we know, it's going to be a mess. So we did the things that I'm going to show you. Even before I knew ISMP, before I knew ISOP, before anything else, with other members of our team, I'm head of the institutional medication committee and head of the clinical pharmacology service. And those of you who were yesterday, I'm also the risk manager of the hospital. So altogether, I have enough people and power to do that, and we did a lot of things. First, policy. Although there is a high alert policy by the Ministry of Health and by our HMO, Clalit Medical Services, there is a list of medication besides heparin, which is an IV, or all the IV anticoagulants, all the oral were not and still are not regarded as high alert medication in the official list. They are not there. I put it on the list. All anticoagulants in my hospital are high alert. It doesn't mean that we treat it the same, but we do something. So this is the first thing, to mark them and say this is dangerous. Because if you do not do it, so it's okay, it's not, but it's now official. This is the first thing that we did. And another thing, in some way I regard the physicians and the nurses and others like children who likes their toys, so you take the toys out of their hands and you regulate them. So one of the things that we did back then, years ago, we took out from almost all department inventories, almost all the anticoagulants. Everything became centrally controlled, like air trafficking. We learned also this from aviation. You don't give the cream to the cat. So, and we took almost everything. Now in our hospital, it's now like 8 years. There is even one doc in any department, only in the pharmacy. You want docs, you need to ask for it, and you need to get an approval, and you need to get the appropriate review, as the JCI is saying, and that's it. And we talk to them, we see numbers, more than 1,000 of applications a year. And our clinical pharmacists, especially the two that are not here because they need to work, are doing all the very, very hard work. And also myself, around the clock, answering during Fridays and Saturdays, people asking, senior cardiologists, we need Eliquis. All right, present the patients. Not approved. Go back. Sent again. So we're doing it meticulously for like 8 years. So you can ask, if they don't have the drug, So it's the first step. It's very, very difficult to do. If you now want to take it out, it's difficult. We didn't give him in the first place, 2012. We looked at enoxaparin. Everybody, nurses like, they had drawers. They had 20 milligrams, 40 milligrams, 60 milligrams, 80 milligrams, and the 100 that I didn't have place to put in. So everybody, it's big, the big boxes. It takes a lot of room, but also you can be mistaken. It's very similar to the Lassa medication, lookalike Sandalex. It's the same medication but different strength, and it's another safety issue. So we did a drug utilization analysis, very, very simple, took out all the data, and saw that most of the departments are using only the 40 and the 60. Almost no one is using the others, so we took almost everything out, left them with 1 or 2 strengths. If you want 100 milligram, which is the only one that is in the list, the official list of the HMO and the Ministry of Health, you have Clexane 100 milligrams, not the lower doses. So, but we took everything out, and if you need them, you just ask for them and you get it. And again, the pharmacist is looking at the prescription before they are dispensed. So also we reduced the enoxaparin dosing errors, some of it. We have written, and it says 2016, every year we have another, it's the same slide I'm using, but we have every few months we are updating. The last one was like this January, right, Amit? This January we made. We are putting designated prescription forms that actually capture the protocol and all the different indication, including the indication for the health basket, because we want the patient to go out of the hospital and receive the medication without needing to pay for it. Okay, there is also the economic aspect. So they have to feel it, the physicians, and this, let's say, makes them more accurate when they write the prescription, because they can know, just a minute, it's not accurate. For example, if you look at the Eliquis, it's written when to give the lower dose. One of the problems that many of the physicians are giving the lower dose when they don't have to. They are giving the patient a lower dose than is needed. So they can look and read it's small fonts, but if you have the form, it's very easy, and it's also in our website in the hospital, so very easy, and we are using it. And the clinical pharmacists are walking through this and seeing if it's right. They look at the medical records and they approve it or disapprove it. Now, we have made a lot of protocols, handouts, and more regarding every aspect of anticoagulants, not just for each anticoagulant, putting a very short, nicely written handout, not forcing the physician to read all the very long insert or the long brochure for of every medication, just the main points so the physician can know about it. Also, we had a few tools, for example, a table, when to stop and when to renew an anticoagulant around interventions, all kind of a protocol for treatments of bleeding, and also for a heparin-induced thrombocytopenia, and so on, and everything is there. And also, this is the chameleon. Also, we use it in all of the Clalit hospitals and other hospitals. So we have a designated protocol, so the physician just need to tick and use it. So it's not something that, and it's part of, you see all those colors, it's the buttons that you click if you need a specific protocol. So as I told you, we are doing a mandatory pharmacist review of all these DOACs prescriptions, and it's more than 1,000 a year, even much more. And still now we see more, not less, more than 10% rejection or correction that are needed. And if you look at that, we are talking, it is not very recently, it became a bit better. And although most physicians now know the medication, are more familiar with the medication, they still make mistakes, especially today that we know more about interactions. And most physicians don't know how to handle interactions. But we do, and we find the different cases that interactions matter and correct the prescription. And we are some of the overruling of the pharmacies is just stop the treatment. It's not relevant for the patient, or change the dose. It can be either increase or decrease, or switch, all kind of switching that we're doing. Yes, he needs anticoagulants, but use another thing. There are all kind of issues. For example, a patient with gastric problems preferably will not put them on Pradaxa relatively to others. So there are a few nuances. So our pharmacists and myself are always trying to read the latest literature to be very educated regarding this part of being up to date and giving the best treatment, being up to date with all the new indications and studies and so on. Another thing we're using, although back then when the medication were presented, they say, you don't need to monitor anything with the dogs. It's not like a warfarin. Today we know we have to monitor a lot of the patients. And we started doing it years ago when we were fortunate that our hematology laboratory is very, very advanced. They were the first in the country, especially in Kalit, to be a pilot center for all the different Pradaxa levels, the hemocolot, and also for the different factor 10A, factor 10 activated levels correlated to the different medications, and we're using them. And there are other monitoring options. It's more like a pharmacodynamics monitoring, not a pharmacokinetics, but we're using it almost on a daily basis. So very, very specific using it, and it's, of course, it's improving. TDM is very important. And one of the things that happens during the years that we send the people to community, and we didn't know what will happen with them. Now, we are fortunate in Carmel that 90% of our patients are actually Clalit patients and living around Haifa. So they are actually, we have a direct relationship with the HMO. And they gave our clinical pharmacists a full permission to put the request and approve all the anticoagulants in the official community. We are hospital, they are community, in the community medication approved system. So if a patient comes and the prescription, as I showed you, is given, and they approve the medication, immediately one of the pharmacists are actually putting the approval in the community. So there isn't any broken telephone connection on the way. So the patient coming out and getting the specifics. So we don't have, so it's a classical dot-to-dot connection that makes it much better. And it was great because we had at first to show that our pharmacists are good enough like other physicians. Today, everybody knows they are better than the other physician because they are much better, and I'm all support for clinical pharmacists in this system of regulation. These are what they are doing. I myself don't have the permission because I just said the pharmacists are doing it better. And it's great for these patients. And patients for other HMOs, we write it in the discharge forms, trying to make it very clear what we recommend so they can approve it. Now, we continue monitoring the use of the anticoagulant, especially the major adverse events. And every time one of the antidotes or the other countermeasures, for example, the Beripex is the proteorbin complex concentrate. It's not a classical antidote. It's not like Proxabine, the monoclonal antibody, but it's a countermeasure. And protamine sulfate or vitamin K, because we have automatic medical records, so we can do all kind of analysis. For example, recent cases of intracranial hemorrhage with Eliquis all survived using this PCC product. We had some incidents at first, and now everyone knows. We had some, at first people didn't know how to use. Amit is now, I can tell you in the break how we made it. For example, this medication, we understand it cannot be in the pharmacy. So we put it in the blood bank when they distribute also the other blood product. So the blood bank technician are dispensing them using a specific form that we had made. One of the pharmacists has edited it. So we have a full control of the uses of all the different countermeasures, and we investigate them and to see if they are used the correct dose. It's about 20 to 50 units per kilo, and of course the outcome. And we give all kind of attention for all kind of other adverse drug events, trying to do the debriefing, as I told you yesterday in my presentation regarding risk management and other surveillance. And education for regarding medical personnel, we try always to make them educated. It's not perfect, but regarding patients, this is something that we're trying to move forward. And one of the last things I want to show you is to make you familiar with something that's it's out there for years, and almost no one is using. This is these are just the first page of the cards, the info cards for patients. This is not something nice to have. This is actually mandatory. This is part of the registration by the Ministry of Health, part of the risk management plan, and it's mandatory for the three companies, Bayer and Pfizer and Boehringer, to produce and to hand to physicians that will hand it to the patient when they prescribe. And almost no one is using these very, very nice tools. I don't say it's perfect, but there's better than nothing. So we are now trying to fill this gap, but I encourage you to go, because do you think that, as we heard in a previous session, also the pharma companies, everybody is interested to make the medication safer. It's the interest of everybody. So producing and giving these cards, it costs a bit of money, but it's much better than dealing with the outcome, the bad outcome. So you have already some nice tools to give your patients, something that they carry in Hebrew, in English, in other languages. You just go into the Ministry of Health medication database, and you see this. You can even download it. There are PDFs, and you can just print them and end them, or ask for the color version. So in conclusion, there is always many things to do. You heard by now. Just go and decide what to do, what is relevant to your institution. It can either be other medications, but the main focus using the ISMP tools and other tools is think very practically what will matter, what will bring outcomes, what will work, and try to be very consistent with it, and don't afraid to be, let's say, like a good parent. Don't be nice to a first. Be hard sometimes, because eventually you are doing good for them. Even if physicians say, oh, why do we need all this regulation? And you show them again and again that they make mistakes. They say, oh, thank you very much that you saved me. And eventually they will, hopefully, they will agree with you. So thank you very much for that.